repeat of the webinar we presented last 10 days ago on Thursday the 15th. We recognized that there were a number of people who did not get the correct webinar link, so we thought we would try again to repeat the webinar. I would, two things, housekeeping-wise. On this front slide, as well as you'll find on every slide throughout the presentation, there is an email address, mrohertyne@nasuid.org. That's mrohertyne@nasuad.org. For those of you that are on the phone this evening, please feel free to send your comments, questions, thoughts, and concerns to that email address, and we will incorporate it into our report as part of our public feedback process. For those of you that are on the webinar today, there is you should see a chat box, Q&A box on the right-hand side of your screen. So I encourage you to, as I go through the presentation, if you have comments, questions, or concerns on any of the topics, to feel free to put those on, fill those in on the chat box, and I will go through them at the end of my very brief presentation. And then depending on how much time we have left and how many participants we have, we may be able to open the phone lines. So we'll let you know when we get to that point. So we've already got a question, which is, what website will the slide deck and the recording be available on? The Nebraska Department of Health and Human Services has a website, a dedicated website for the redesign project. And we'll have that web address at the end of the presentation on the last slide. The recording from last week's webinar is up now on that web page, as well as this slide deck that we used last week. So if you're able to get to that for whatever reason and you'd like to look at it, it's the same content as we've been presenting in all of our listening sessions throughout the state. So we'll go ahead and get started. I will let you know that if you have any technical assistance problems, the webinar blanks out, you are not able to hear me, etc., please contact Allie, our Wonder Woman at the office here in Washington, D.C. Her phone number and email address are on the slide deck. For those of you that are on the phone, for whatever reason, if you run into problems, that phone number is 202-999-6766. So without further ado, we'll go ahead and get started. So what I'm going to go through today is talk a little bit about the redesign project, why the state's undertaking this effort right now, the areas of interest and concern that the state has laid out in the LTSS redesign concept paper that was published in January of this year. Then there are specific questions to drive thought and feedback on each of those topics that I offer you the opportunity to share with us, either now in writing on the chat box or by email at the bottom of this slide. And then we'll talk a little bit, I'll talk a little bit about next steps. So you've already heard me say two different terms, long-term services and supports or long-term care. The term that we're using, the way we're using it for this project, those terms are interchangeable. We've identified that the term long-term services and supports is a pretty recent development, and many consumers in particular still think of those types of services that are delivered in the home to help keep people in their homes as long-term care. So we're using that term to make it more accessible to everyone. But you can call it whatever you'd like, whatever your preference is. So as I mentioned earlier, the state is considering changes in the long-term care system for a number of reasons. The population across the country, not just in Nebraska, is aging. 10,000 people every day are turning 65, and the fastest growing segment of the population, again across the country, are those 85 years old and older. On top of an aging sort of demand for services, the workforce is also aging. We're losing providers on a fairly rapid basis as they hit retirement age. And then finally, last but not least, Medicaid costs, the cost of the Medicaid program, continue to grow. Medicaid nationally, as well as in Nebraska, is taking a larger and larger chunk of state budgets, which means that Medicaid is squeezing out other really important priorities that states have, including education and transportation. So the state has looked at all of these factors coming together and determined that the current system, the way it's running, is not sustainable. It can't be maintained the way it is, and so changes are necessary. So the state has hired help for this project. Our organization, NASAWID, which is the Membership Association for State Directors of Aging and Disability Services, is partnering with Mercer Government Human Services Consulting to help the state analyze their system, talk to stakeholders, and provide a redesign plan. So the first step in that process is actually these listening sessions. We're in, on this slide, 6. We're currently in September, finishing up the last of our public listening sessions that we had over the last 3 weeks across the state. That feedback, as well as the information that we've gathered from talking to the state staff and state leadership at DHHS, will all be fed into a long-term care redesign draft plan that we will be delivering to the state shortly after the holidays. That'll be published and will be available for review and comment in the wintertime. The team from NASAWID will be going back out on the road to the same cities that we visited earlier this month to do another round of listening and talking about the specifics that are in the redesign plan. Armed with that feedback, we'll go back, the team will go back, incorporate those, provide that information to the state, and present a final redesign plan next spring in May for the state to determine next steps. So the goal of the project is really to make the system better functioning for Nebraskans. You know, to make sure that people are healthy, that the services that they provide are high quality. Very importantly, that individuals, consumers, get to live the life that they want in the location that they want, and that they're able to manage and navigate the healthcare and social support systems. And then last but not least, as I said earlier, to ensure that that system as a whole is affordable and manageable for the state. So the redesign project is focused on Medicaid-funded services that serve individuals with disabilities and older adults and their caregivers. But we recognize that Medicaid isn't the full scope of services that individuals might be receiving, and so we're interested in ideas, concerns, or thoughts you have about other programs that help individuals lead healthier and meaningful lives. So some of the areas we've heard already are the education system. We've talked about transportation, housing, some of those issues that are sort of outside the scope of the Medicaid program, but very definitely impact folks' ability to live their lives. So the 6 main areas that were in the concept paper that was released again in January that we've distilled into this presentation include asking for feedback on how the system itself runs, how to assess the needs of individuals who need long-term care services fairly, how to improve service coordination and case management, how to help individuals receive the services and supports that they need, how to make it easier so that more providers participate in the long-term care program, and how to improve the quality of services. Again, I'll continue to remind you that if you have questions or comments, to put them in the chat box or to send them to the email address that's on the bottom of the slide. So the first area is how to improve how the system runs. The state in the concept paper identified a number of issues in the current long-term care system, and that's sort of really a lot of diversity in the number of programs that are out there for individuals, how those programs operate, the rules for getting in, the rules for accessing services, the types of options that individuals have for getting services, and then, frankly, different types of services. So that all leads to a lack of clarity, a lack of understanding about what's available broadly, and then fundamentally can lead to delays in getting into the system. So the kinds of issues that we're interested in hearing about are things like what works well in the current system. Obviously, if the state is redesigning their program, they don't want to lose the things that work well, but recognizing that there are definitely areas for improvement. So asking what would make it easier for you, your family members, caregivers, providers, easier to get into the system. Are there services that you think would be helpful for you or your family members that you aren't able to get in the current program? And then finally, I think this is something we've heard really loud and clear over the listening sessions that we've had, is how to get into the system, how to actually enroll into Medicaid, how to qualify for long-term care services, and then how to get those delivered. So this first section is really focused on the front door of the system and how you access it and what consumers and providers experience when they begin working their way through the long-term care system in Nebraska. The second area where the state is seeking feedback is in the area of assessments. Looking at ways to fairly assess the needs of people who present for long-term care services. And again, we found a lot of diversity in the current system. So depending on who you are and how you qualify for Medicaid, your needs may be assessed differently. The assessment that you get and the program that you're enrolled in can lead to lots of variation in the kinds of services that you can get. And then, sort of a theme, back to the same issue of services are different across programs. So you could use services in a particular type of program, but that's not available to you because you're in one specific program and not everything is available to you all at the same time. So these are significant issues that are causing problems for individuals using long-term services and supports. So one of the areas, so the state is very interested in having you think through and give us feedback about ways that we could change the assessment system so that everyone is assessed fairly for the services that they need. And then once that assessment sort of evaluation is completed, how can that data be better used to figure out the right kinds of services that individuals need? So again, I'll pause here for a minute and encourage you, if you have thoughts about this particular topic, to put them in the Q&A box that's on the right-hand side of your screen, or for those of you on the phone, if you have an opportunity to email those questions to mrohertyne@nasuad.org. The third area of concern, or ripe for sort of a rethinking, is how to better coordinate care for folks using long-term services and supports. So across the country, different terms are used. Primarily, it's called service coordination here in Nebraska. In other places, other programs, they might call it care management or case management. All of those terms are sort of interchangeable for the concept of someone that can help a consumer navigate the system to make sure that they get the services that they need, and they don't fall through the cracks, and that they help identify gaps in services and try as best they can to get those filled. So somebody is a helper through the long-term care system. And what we found is that based on the program, some consumers in Nebraska aren't able to even get service coordination or case management, especially if they're receiving home health services, personal assistance service through the PASS program, and private duty nursing. That leads to those individuals in particular who might need help with finding providers or getting access to services don't actually get the help that they need. We've identified that for those that do have a service coordinator, very often they may not be aware when the consumer has a health crisis, for example, returns home from a hospitalization or a stay, or a rehabilitation stay, and that might call for more services. They're not aware of that to be able to rapidly address those needs. And then finally, we've identified that there may be conflicts in the system, so that those who are doing the service coordination and helping people identify and get services, in fact, may sometimes provide those services as well, which is a concern. So given that landscape around service coordination, the state is interested in these kinds of topics. So asking about the types of help that might be helpful for getting around both the long-term care system as well as the healthcare system. Identifying types of people, types of consumers that might need more help than other kinds that aren't getting that help today. If there's a particular type of service coordinator or tasks that they should be doing for you that would be helpful. And then really asking about the system being person-centered. That means that rather than the person being fit into sort of boxes based on what's available, the services are wrapped around the person based on what's important to them and their own needs. So really flipping the paradigm from having it be service-based to having it being and provider-based, having it be person-based. And that's a really important concept that could definitely assist individuals in feeling more satisfied with their services and getting the kinds of services that they need. So again, this is another topic, the third of the six that we're going to talk about around service coordination. Welcome you to put questions or comments about this topic in the chat box to the right, and also if you'd like to send an email to that email address, mrohertyne@nasuad.org. The fourth area is looking at the services and supports that individuals get. The fourth area of the concept paper. And what we're finding is this is really around duplication and gaps in the service system. So we've identified, the state's identified that several of the long-term care services that are available are similar, very similar, called different things in different programs, but essentially serve the same function. That can lead to consumers getting services from different programs at the same time without those two programs knowing about the services that are being provided by the different programs because they're in very separate, run in separate systems. Leading from that, we've identified that policies and staff training are very different between programs. So depending on the why you qualify for Medicaid, you can have a very different interaction with the state and local staff. And then, again, circling back to the same topic I talked about a little bit earlier, some services that might be beneficial to certain folks in one of the programs isn't available to them because that particular program doesn't offer that set of services. So the state is interested in asking for feedback on changes to that sort of, we've been using the term siloed systems, sort of standing up next to each other, but really not at all integrated or touching each other. How should the state help individuals who have new healthcare needs get help? And then finally, if there are any ideas or concerns or breakdowns currently in the communication and coordination of services between different programs. So we've heard that consumers moving from the child system to the adult system have very different experiences and have access to different services. So how could that be better managed to lead to better outcomes for consumers? The fifth area is how to encourage more providers to participate. This is a critical area, as I talked about at the very beginning, the lack of providers. What has been striking to the team as we've gone through the state on the listening tour is the very low unemployment in Nebraska, which normally would be a good thing generally, but it's causing a lot of stress and tension on the long-term care system as there are simply not enough people to deliver services that the consumers need. So this is a very, very critical area. What we've identified so far is providers have very different experiences based on the program that they are participating in. They don't have the same process depending on what program they're providing services for, and that sort of provider enrollment process that they do go through is only good for one program. It doesn't sort of put them in the list for other programs. We've identified that reimbursement rates or the payment rates that providers get vary between providers that are providing similar services but are differently situated. And so there's an issue of sort of equity and fairness and that issue across providers. And then again, providers could be providing very similar services in different programs and get paid very differently. So rationalizing the provider engagement and payment process is a critical part of any redesign system. So some of the areas that the state's interested in getting feedback on include, are there ways to improve how the state pays providers for services? Are there ways to make the process easier just like I mentioned at the very beginning, the front door for consumers. Is there a way to make the system friendlier to providers as well? And that includes not only enrollment, but paying for services and submitting claims. And then making sure that providers have the appropriate training so that they can provide high quality care. So again, I'll encourage you to put your comments in the chat box to the right, or send an email to mrohertyne@nasuad.org. The sixth and final, not really final, but the sixth area that the state is very interested in is how to improve the quality of long-term care services that consumers are getting. And this is a pretty straightforward issue, which is not just in Nebraska, but nationally, measuring the quality of long-term care services is very challenging, especially those services that are provided in folks in people's homes and in community settings. And so the state's very interested in making sure that whatever the services that are paid for are of the highest value, and that means that they provide good quality care and they make a difference in people's lives. So the state has made some early initial efforts in a more person-focused quality system, but there's definitely opportunities for expanding that concept broadly across the system. So we're very interested in the information that the state should have to assess whether the services are of high quality, what they should know, what the state should know to make sure that the services are effective. In the end, for long-term care services that are so personal and unique to individuals, quality is really what matters most to you. And so interested in the kinds of things that the state should be looking at. What are important to you? How would you define a quality service if it was being delivered to you? We're very interested in that feedback. I said there were 6, but there are actually 7 items. And the last is really what I call a very broad overarching theme, which is how to improve how the services get delivered. So we've talked about the front door. We've talked about the types, how people are assessed. We've talked about the types of services that are available. We've talked about service coordination. We've talked about providers. We've talked about quality. This last piece is really looking at the whole system, all of those components, and what is the best way to make sure that the services are delivered effectively and in a high quality manner. And so this is the state's goal, is to make sure that whatever changes are made in the system, they meet the needs of the consumers in Nebraska who need services, long-term services. So what we've identified, I'm sure you've pulled from the topics that I've covered already, that the long-term care services are really divided and separated, very separate from the healthcare system, one, and then within the long-term care system in these buckets or silos where you're in a waiver program or you're getting a certain kind of service, and it is really not connected to anything else going on in the system. So there are different computer systems that manage the different programs. The kinds of care manager you get changes, or either you don't have one or it changes based on the program that you have if you move in and out, and there are different payment systems. And so sort of putting all that together and being able to manage a system that large is a challenge for states, not just in Nebraska, but across the country. And one of the trends that is one of the tools that states are starting to use more and more frequently is a managed care system that would allow the health plan to focus on the whole person, both their physical and their long-term care needs, and eliminates some of these silos where the programs have been currently operating. We know, recognize that the state talked about moving to managed long-term care 3 or 4 years ago, and that it caused a lot of anxiety for people. And so this is really an opportunity to have you and other Nebraskans across the state share those areas of concern, the things that you'd be the most concerned about if managed care should come, things that are good in the system that should be maintained, or any of the benefits that managed care could offer to the long-term care system in Nebraska. So these are the overarching questions that we're very interested in getting feedback on. You know, what hope or fear do you have about the redesign? What should the time frames be for any changes that are coming? What are the challenges, the biggest challenges in changing the system? What services would you be most afraid of losing in any new system? And what good things have you heard about managed long-term care? And what have you heard about that's not so good, potentially in other places around the country that Nebraska should avoid if the system redesign moves in that direction? So again, I'll encourage you to provide comments in the chat box to the right. And for those of you on the phone, if you wanted to send comments on this topic and any other to mrohetyne@nasuad.org. So those are the key areas the state's asking for feedback. The next step is we have, in fact, held listening sessions. We continue to read any correspondence, any and all correspondence that comes either to the state's email address or the one I've been touting throughout the presentation. We've been meeting with provider groups, consumer groups, and holding those listening sessions. And then, as I said earlier, we'll present a redesign plan and then take it, as we call, back out on the road to the same 7 cities that we visited earlier this month. So this is the slide that will provide you the web address for the Medicaid Long-Term Care Division, Medicaid and Long-Term Care Division redesign page. It's on the DHHS website, and it's dedicated to the redesign. So you should be able to find that fairly easily. On the slide also are the email address that's at NASUAD that comes to our team based in Washington, D.C. There is additionally an email address that goes into the DHHS offices, long-term care redesign at nebraska.gov. And those are being forwarded by the state staff to us to be folded into our stakeholder sort of assessment and report that we're giving to the state. And for those of you that are really interested, there's a Twitter handle. There's also the Nebraska Medicaid Facebook page where you can get information. We're posting materials regularly. So that brings us to the end of the formal presentation. This is a little difficult when there's no interaction. We typically stop when we've been doing these listening sessions and have a conversation with the folks that have been able to turn out in Omaha and Lincoln, Fremont, Norfolk, Kearney, Grand Island, Scottsbluff, Gearing, and North Platte earlier this month. So I'm hoping we've got several questions and comments in the chat box. So I'm going to try and read this very tiny writing and hopefully be able to answer some of those for you. So the first question was, who will be representing the DD population and providers? I'm not sure exactly what that means, but we have had extensive conversations with providers who work in the DD waiver. We have been talking to consumer groups that represent individuals with intellectual developmental disabilities, and also talking to the state staff that administer that the DD waiver. So I think we've gotten some very good feedback specifically unique to the issues of the DD IDD system. Comment, there is absolutely no assistance for individuals with both mental health issues and intellectual disabilities. Providers in each specialty defer issues to the opposite specialty. This population is not underserved, it is non-served. That's a great comment. We have heard the intersection of individuals with developmental disabilities, both with the mental health system as well as with the aging system, as those individuals continue to age into sort of the older adults programs. And we have identified that, we've heard that very clearly, and are identifying that as an area for to be addressed. And again, the systems are very separate today, and there's an opportunity there for better integration. Next question, is the plan to have all services under managed care, including certified providers? The state has been, I think, pretty open about the fact that managed care is definitely a possibility. They've identified that as one of the best options for integrating services for people across the spectrum, so that individuals aren't sort of chopped up based on their diagnosis. And if that were the case, the decision hasn't been made, but in most states across the country, that is the case, that all services are under managed care, and that includes all the providers that deliver services that are in the managed care contract. So that remains to be seen, but that typically is what has happened in other states. Please complete unbiased independent pilot programs in rural and urban areas for any potential changes before implementation. Okay. That's really good feedback. We appreciate that. I think some states have taken that approach to pilot in certain new delivery options in certain areas of the state, and so we'll provide that feedback to the state. Comment, I'm afraid that specifically extended family homes for people with intellectual disabilities will either be lost or completely underfunded. That they will be, and which will make them impossible to provide. Thank you for that comment. We've heard a lot about extended family homes and their role in serving individuals with intellectual disability in Nebraska, and so that's a great feedback about a service that really should be retained in any redesign system, and so we'll have that noted. Question, can we print out the PowerPoint? You cannot from this presentation. We don't have the slide deck made available through this system, but again, the same material is currently available on the Medicaid and long-term care website for the redesign page. There's a PowerPoint presentation. It's essentially the same slide deck that we've been using for all of the listening sessions, and you're free to navigate to the website and print it from there. So that's available. And if you somehow received the invitation for the webinar from NASUID, when we sent it out, the PowerPoint was attached. So if you'd like to, and that's complicated, please send your name and an email address to the mrohertyne@nasuid.org email address, and we'll be happy to email it back to you so that you can print it out. Oh, wonderful. Comments just keep coming. Next comment, is there a stakeholder group or other groups that you can join to be part of this redesign process? So there is a long-term care advisory council the state has commissioned that is providing feedback to the process. But what I think is really commendable about the state's approach to this redesign is that you don't have to be part of a stakeholder group to provide feedback into the process. The listening sessions have been open to anyone who wants to come. The email addresses have been widely published for you to provide feedback. The state staff have been out and talking about this system. We've been meeting with provider groups. So I think there have been lots of opportunities for your voice to be heard without having to be part of a specific select group of individuals that the state's consulting with. It's been a very open process for folks to provide feedback. Wow, okay, it's moved. I got so many that's moved. Where do I find more information about managed care? That's a great question. It's one of the things that I spend a lot of my time here in Washington focused on, helping states with their managed care programs. There are a couple of good resources. If you want to hear about sort of managed care broadly, just how it works, Heritage Health is rolling out in January, and so there's an opportunity to just learn about how it operates broadly through information on the state's website. A couple of really good resources, sort of basics about managed care and how it works in long-term care, is the Kaiser Commission on Medicaid and the Uninsured at kff.org, has really good basic information about managed care, the expenditures, how it works, how long-term care is impacted, and those are some really good, easily accessible consumer publications that you should be able to download. And it won't be specific to Nebraska, but it does have some really good basic information about managed care, the principles, and how it operates. Sorry. Question. I'm afraid that upcoming change is a repeat of the past. I'm afraid that individuals will end up in cheap services with inexpensive, untrained, unskilled providers. I'm afraid that this in turn will revisit the abusive horrors of the past. I think that those are, we appreciate that comment. I think those fears are real and are worth paying attention to. I will tell you that the success of any redesign is really the focus and the attention of the state staff who are implementing the change. And we've been, NASAWID provides services all across the country to every state that works on aging and disabilities. So we see lots of programs. And I will tell you the engagement and the sincere interest from the leadership at DHHS to build a system that really does work for individuals is really refreshing and is compelling. And so I think that no one wants that to happen. The system, we need to move the system forward in a high, with the highest kinds of quality, with skilled and trained providers. And the ability to do that really depends on the system being more efficient and change. So we will definitely take that and make sure that that's reflected in the comments. Thank you. Next question, will the waiver program still be in place for children with disabilities? That is one area that needs to be simplified significantly. Parents rarely understand how to apply and qualify for the program. Wow. We have heard that in every single setting that we have been in the last 3 weeks. It has been a repeated theme of the complexity and the difficulty of parents with children with disabilities, of how to access the system, the difficulty in qualifying, and then figuring out what's available. And so those programs are intended to stay in place. There isn't any intention to reduce services, but to make them work better and more efficiently. And so that front door process education, good information from the schools to parents, as well as during the transition from the school system to adult services is really a gap area and needs to be addressed. We've identified that already and talked to the state about that. They recognize it too, obviously, and so that's one of the key areas, is just better education and making it simpler for people to understand what's available. Will this redesign also include services currently being provided through the Older Americans Act and the State Unit on Aging? No. Right now, this is focused on Medicaid-funded services, primarily. The services provided under the Older Americans Act obviously is funded by a separate arm of the federal government and are important, but are not central to the redesign at this point. But if there are opportunities, as we said earlier in the slide deck, if there are other programs that needs to be addressed, or there are some, the same issues that you see in Medicaid are in those other programs, those should definitely be brought to the state's attention to see if they can be addressed at the same time. It is taking 10+ weeks for CLDS, I'm not sure what that means, providers to go through checks, and this is turning many off and hurting areas with small populations. Will there be any changes to this? I'm assuming that this is a reference to the new provider enrollment process through Maximus, and that's also comments that we've heard in all of the public meetings that we've had across the state. The delay in getting providers enrolled has actually caused providers, they can't wait because unemployment is low. They will move on to other jobs. They can't wait for the time it takes to get to get through the screening system. So yes, it's we have heard that there are improvements, that the system is speeding up, but it's still delayed. And I know that the staff at Medicaid and long-term care are working diligently with Maximus to do as much as they can to expedite that process, because they recognize the impact it has to availability of providers. Question. The current assessment used in developmental disability services programs do not assess for mental health needs. This needs to be addressed and via the assessment process for supports. We heard this also. It's a great comment. We've identified, we've heard from multiple providers that mental health service needs are not identified. It's really focused on simply the services related to a person's intellectual or developmental disability, and the compounding factors involved in mental health issues makes it difficult for those assessments to accurately reflect the kinds of services that folks need. That's a great comment. It's already been flagged and noted, but we're glad to hear that it continues to be an issue that folks are concerned about. Managed care has been known to remove current case management agencies and bring case management in-house, removing objective case management oversight. I ask that any managed care agencies be required to contract with current case management agencies. I think that's a great comment. We've heard that a couple of times across the state. Depending on the managed care company, some have a philosophy of contracting with current case management agencies or current case managers or care coordinators, service coordinators. Others prefer to hire within and bring folks on inside the health plan and do that work internally. The issue about objectivity, I think, is again related to the state's oversight of the managed care program. The mantra that I say regularly when I talk to states about managed care is that the managed care program is only as good as the management of that the state has over the program. You know, managed care is really just a tool. It's a tool like anything else in a state's toolbox, and a tool that is wielded carelessly or without consideration for the environment that it's in leads to adverse outcomes. And so it's really incumbent on the state to build an oversight process that's rigorous and ensures that individuals are getting the services that they need and case management is appropriate and assessments are adequate. What regions are you visiting? You mentioned you're visiting 7 sites. What are they? So our team started in the East Labor Day week, and we held public sessions in Omaha, in Lincoln, in Norfolk, and Fremont. And then 2 weeks ago, we were in Grand Island, and then had the first presentation webinar that we did at Nebraska Educational Television in Lincoln. And then last week, our team was in Kearney and North Platte and Gearing in the public libraries in most of those towns. And so we'll be back to those same towns, cities in the spring when the redesign plan, the draft, is available. Extended family homes is a service that can and should be available for all populations needing support, including aging individuals. So there's a good example of services that are specific to specific types of populations, and so that's a great feedback note. Why is staff not cross-trained? Again, we've heard that that feedback from the public sessions we've had already, that the staff, both who are working on individual programs, understand their own program and aren't aware of the resources that are available in other programs. And so that's already been identified as an opportunity for improvement. Does switching to a person-based system rather than a provider-based system mean that the new long-term care model might employ the same model as the foster care system, making the extended home providers pay more like a foster parent for individuals with DD? I don't know. That question has not come up yet. I'm sorry to say that I don't know enough about the foster care system and how it operates, but that's a great comment that we haven't heard before, at least our team hasn't heard before, and we'll identify that and flag that for conversation and analysis with the state staff. We have heard rumors that the state is planning on having providers become Medicaid certified, requiring the individual to be in the quote-unquote right network in order to be with that particular provider. I don't know. That's not something that's been, it's a nuance that if it is being discussed, it's not something that I think we have heard before or aware of, but we'll definitely share that feedback with the state. If the state does go to managed care, does that mean that we lose our service coordinators that we currently have? It really depends. Most states, when they move to managed care, well, one, they're required by federal regulation to allow the services that are currently in place for a period of time to remain in place. Many states take that not just for the services, but also the care management staff. So there's that possibility. As I said earlier, a number of health plans will hire the service coordinators that are currently case managing folks, and either bring them on to the managed care plan staff or contract with those entities to maintain continuity. The goal is definitely to have as little disruption to individuals' lives as possible with any redesign change. Change is tough, and when these services are so personal and are such a big part of folks' everyday life, it's even more critical. So it's definitely a concern that I think the state will take under advisement and figure out how to minimize as much as possible. There has been much discussion about the closure of sheltered workshops toward community-based employment. Is this part of the redesign plan at this point in time? Well, the conversation about sheltered workshops and focusing on integrated community-based employment is not directly related to the redesign, but it is a part of the state's work to become compliant with the new federal regulations on home and community-based services, where in order to be considered home and community-based, individuals need to receive services in the least restrictive setting and in the same manner as somebody who doesn't currently get Medicaid. So opportunities for individuals, if they want to work in the community, to work in the community, and to not have, to minimize segregation and isolation for individuals with particular types of disabilities. So the state's working on that already because they need to be compliant with those requirements by March of 2019, but obviously all those efforts feed into the system, the considerations for a system redesign. So while not directly, it is definitely related. How will the state ensure that providers will be paid a reasonable rate that will allow them to provide adequate care to the consumer when managed care companies continue to reduce rates and use their leverage to force providers to accept lower rates? I'll circle back to my earlier comment about the state really driving the terms and conditions of a plan's entry into a state's health insurance system, whether it's acute care, health care, or long-term care. Many states across the country, in order to minimize disruptions to the provider network, do require for some period of time the health plans to honor current payment rates for providers. Some cases, those rates today are too low. And so maintaining that, those rates are challenging. And so health plans have, in fact, figured out that it's beneficial to consumers and to the long-term health of their population to actually pay more. It's not always the case, but it does happen. And so I'll go back to, it's about the state and their expectations and requirements on the health plans for managing their provider network appropriately. With access and provider capacity and adequacy issues, it wouldn't make sense to reduce rates to drive providers out when there's already a provider shortage, especially in some critical areas. So I would expect the state to be spending a lot of time on the provider part focus of any managed care delivery system. Bottom line is that the state wants the same or more services for less money. The highest expense in any provider budget is wages. You cannot get quality staff now since we cannot afford to compete with fast food and Walmart. Absolutely have heard you. And that's the challenge of a system that is, potentially inefficient and not getting the right services to folks at the right time that they need to remain healthy. So it's definitely a challenge, and the state is not going about this redesign to save money. They've been very clear that it's a way they want to use the funds that's currently allocated as efficiently and effectively as possible to deploy them. So rethinking the way the system is designed and operates will hopefully lead them in that direction. The HCBS waiver system for individuals with DD is going through significant rate methodology changes, and funding will be cut beginning October 1st. What will this do to the funding changes in process through DHHS due to CMS requirements? I can't answer that question. We'll forward that question on to the folks at the Developmental Disabilities Division, who Courtney Miller, the director, joined us on most of the public sessions, actually every public session that we had, public listening session that we had in the last 3 weeks, and spent time at each of those sessions after the redesign conversation talking about the changes that were coming to the DD waiver process. And I know that she will we'll send this to her and let her address that question. It's not something that is specifically focused on redesign at this point. It is vital that extended family homes are continued to be reimbursed under the same as foster care homes moving forward. How this will be possible once things move to managed care. Again, I'll repeat, we've talked a little bit about provider payment, but again, it will take a careful assessment of how payments are currently made, and changes, any changes that are necessary, I hope will be, deliberate and thought out And, you know, with long implementation timeframes, which we highly recommend, which CMS highly recommends, and I think which DHHS already recognizes is necessary, there will be time to iron out those specific details for specific provider types. Why are case managers unaware of health changes? Why is there no follow-up? I think fundamentally the issue is that the systems are completely siloed. A service coordinator who's serving somebody with who's helping a waiver client, there's no reason for the system to alert the service coordinator that somebody's gone into the hospital after a fall, for example, or because of an emergency surgery. And so when, if they're not aware that they've gone in to the hospital, they can't be prepared to make any changes in the services that individuals need to make that transition home. The discharge planners at hospitals aren't always aware of waiver services and that there are service coordinators out there. So it's again a result, I think, of the separate systems that folks interact. You know, they're in the long-term care system, they're in the medical system, and the two don't really interact today. Could you provide any examples of states where the change to managed LTC Medicaid services was extremely positive? We mainly hear the horror stories. So some positive examples might help alleviate anxiety. Yes, I think there are some very good stories around the country. Tennessee is generally held up as, I think, one of the most successful programs in the country for managing the transition from fee-for-service. They've only had managed long-term care for 6 years. They're in their 6th year now, so they came to it fairly recently. But they had a long history of having medical managed care, sort of the equivalent of a Heritage Health program in their system. So they were very thoughtful, and they knew exactly what they wanted to do. And the staff in Tennessee has the most rigorous contracting and oversight requirements, I think, in the country, generally agreed. And the director there had 2 principles for their transition. One is consumers get services, and the second is providers get paid, which is, you know, fairly obvious. To minimize disruption, individuals really need to feel like the change is seamless to the maximum extent possible, and providers need to not have any adverse circumstances from moving to new payers. And so it's been a very positive experience. They have been very successful in moving individuals out of nursing facilities and into community settings where those individuals express preference to live in the community. Arizona's had a very long time managed care program. It's hard to really compare them to the rest of the country because they've always had managed care, but it runs very, very well, very high satisfaction, and providers are pretty happy with the way the system works. New Jersey has had a recent implementation, only 2 years old, and their transition, again, has been very, very smooth, very positive. Very few issues, but again, the state took a lot of time. They have built a very rigorous oversight process. They're holding their plans very accountable for performance, and so that experience has been a very good one. And then I'd also point to I do this a lot and people laugh, but Rhode Island and Massachusetts, I know, very small states, very unlike Nebraska, but they have had very good success in moving their programs into managed care. Again, a combination of good long time frames for implementation, strong state oversight, and plans that are really partners with the state to do a good job as opposed to just purely contractors. So that's enough there. When children with severe disabilities become adults, their cares do not become less, they only increase. Why is it such a struggle to continue to keep them in their homes after they become adults? Will managed care help with these issues? We have heard this concern raised. It definitely is a flashpoint for around the transition, and depending on the way the state designs the system, have every incentive to try and get in homes where the majority of folks would like to be served and receive their services. So again, it depends, but it's definitely an area of focus for the state. How will this affect the League of Human Dignity and area agencies on aging organizations in regards to home and community-based programs? Well, to the extent that both the League and the AAAs are currently doing assessments and care service coordination, they're obviously impacted by any redesign. Specifically, again, it's a little hard to say because the redesign plan's not done yet, but definitely as their current providers in the system and very important parts of the system, it's probably unlikely that they would not be affected. How, I think, remains to be seen based on the redesign plan. Will the providers be negotiating their rates with MCOs, or will DHHS set those in the future? Again, that's to be determined. I don't really know. It really depends. Centene Corporation has the largest managed care LTSS program and has a lot of information available as needed and on our health plan website. So that must be someone from Centene, they are a large national contractor and they do serve a number of LTSS plans across the country. So I'll share that. Payments shouldn't be demographic. Are rural areas being paid as much as urban areas? I can't answer that, but it's a good question related to the sort of payment equity for providers across the system, so that we'll be sure to flag that. Who measures long-term care quality and how is it measured? Wow, we could be all day on that question. Well, the state is fundamentally responsible from CMS to ensure that the quality of the long-term care services is maintained, and different states use different approaches. Today, the National Quality Forum issued a report on home and community-based quality measurement, talking about sort of what's out there in the system today and where there are needs for states to do more around quality measurement. And so I would encourage anybody, if you're interested in this topic, it's a pretty easy read, fast read, talking about the things that are considered important to consumers and providers in home and community-based services. It's on nationalqualityforum.org if you wanted to take a look at that. It's a good resource. Please keep the system transparent, simple, and standardized. Managed care has a tendency to overcomplicate and create savings through confusing billing processes, delaying authorizations, and one-sided provider rate negotiations. Period. Thank you. That's a very concise statement. I appreciate that. That is the goal for the system, and so those are important considerations for any redesign. Thank you for that comment. I hear you telling us that the state has had an open process. However, many of us were only made aware of funding cuts and this project on Monday. The information was not properly distributed by any and all providers and contractors. I really apologize for that. We've really made truly systemic. We've really tried hard to get the information about these, the listening sessions in each of the cities, and the webinar last week and this week available to anyone who's subscribed to the Developmental Disabilities Division listserv, anyone who's subscribed to the web page that's up on the screen for MLK to MLTC. We've asked all of the key provider groups, the members of the Long-Term Care Redesign Advisory Council to send out the notices. Press releases went out. We've tried really hard, but we would welcome if there are better ways to make people aware of the opportunities to provide feedback and comment. If you could follow up with an email, we'll make sure to incorporate those additional avenues in the spring when we come out for the second round. What type of oversight will the state have in place for handling issues that providers have with managed care companies? I think that remains to be seen. It really depends on the design and the state's design and how they want to manage and oversee the relationship between health plans and the providers. So we'll put a pin in that as a concern for any managed care design. Thank you for that feedback. What about IntelliRide? Would the transportation system also be revised? That's a possibility. We've heard issues with access to transportation, timely, about payment, have come up across the state, and those have already been, because that's the existing system, we've already flagged those to the state staff as we've heard them over the last couple of weeks. But to the extent that transportation is part and parcel of the long-term care system, yes, it would be potentially impacted by the long-term care redesign. I believe it is important to complete routine in-home visits for any case management. My fear is some managed care companies are primarily phone contacts for care management, and the case managements are even housed in other states. Again, I'll repeat, those requirements are set by the state, period. And if the state requires in their contract that case managers are housed in Nebraska, and if they require that the managed care companies must do in-home assessments and face-to-face visits at least as frequently as is happening now, they can do that. So I will leave that there. That's a design and oversight decision, but we hear that it's an important. DD is starting to streamline aging and disability services and definitions with, so Developmental Disabilities Division is starting to streamline and coordinate definitions and services with the aged and disability waiver. It would be beneficial to streamline all waiver services and definitions so that providers can serve all populations. We absolutely hear that. That's part of the issues around the silos and different services and different provider requirements for different programs. So that process is already underway. Foster care and extended family home is very different and should not be funded the same way. Okay, so we've got competing thoughts there between two different commenters. There is a stakeholder meeting tomorrow at 10 a.m. that anyone can attend or call into. Okay, I don't know who's hosting that, but hopefully that information is available on the state website. In your experience, were regulations updated quickly along with the changes moving to managed care? Here we seem to try to provide services under outdated regulations. Is there a plan to address this? I won't speak for the state, but I was lucky enough to be in a meeting with them last week where they were in fact talking at length about plans to update regulations. So you're right, all pieces of the system sort of need to move in concert with each other. It doesn't do any good to revise service definitions sort of operationally without making sure that those match the regulatory in sort of the regulations that cover the program. Provider manuals have to match, consumer information needs to match. It's it really requires a step back and looking at the whole scope together and making sure that all the pieces, I refer to it as sort of taking every strand of spaghetti and laying it out to the very end to make sure that the state understands exactly what needs to happen to make the whole change work and all the pieces that it impacts. And that does take time. And so I think that's why the redesign process is being very deliberate. I think that is all the questions that we got, and we're over time, so I really apologize. I'm not a very good time steward, and it's late here on the East Coast, so I apologize that we've gone over. Again, I want to thank so many of you for participating today, those on the phone, those who are on the webinar. Again, if we didn't get to your question or it wasn't answered adequately, please send in additional information to either of the email addresses. Subscribe to the web page so that you'll know when anything new comes out. So for example, when the redesign plan, the draft is released in January, and the meetings are set, the public meetings are set, the web page will automatically notify your email when there's something new posted on that page. We get it as consultants, we're getting those regularly as the state posts them. This recording will be posted for you to listen again or to share if there are colleagues or friends, family that wanted to hear. That'll be available before the end of the week. So thank you very much for your time and attention today, and we look forward to seeing you all hopefully in person next spring.